السلام عليكم ورحمة الله وبركاته. كل عام وانتم بخير ومبارك عليكم الشهر جميعا. If you have any question, you can type in Q&A or chat.
My presentation today is entitled Optic Neuritis. In this presentation, I will discuss clinical aspect of optic neuritis, present results of optic neuritis treatment trial, point out limitations of optic neuritis treatment trial, and in the last, highlight latest research publications addressing limitation of optic neuritis treatment trial. In classical sense, optic neuritis means inflammation of optic nerve. But inflammation of optic nerve can be due to ischemia, demyelination, pressure on optic nerve, drugs or toxins, etc. But there is an unwritten understanding among ophthalmology and neurology community that until specified otherwise, the term optic neuritis connote that cause of inflammation is demyelination. For inflammation of optic nerve due to ischemia, compression, drugs, toxins, etc., we use other specific terms. If etiology of inflammation of optic nerve is ischemia, we call it arthritic or non-arthritic ischemic optic neuropathy. If etiology of inflammation is drugs such as hydroxychloroquine or toxin such as methyl alcohol, we call it toxic optic neuropathy. If the etiology of inflammation is compression or pressure on optic nerve, we call it compressive optic neuropathy. And if despite workup, we do not find any reason for inflammation, we call it optic neuropathy, not optic neuritis. In simplest words, optic nerve is a white matter tract. So any pathology of white matter can affect optic nerve, such as multiple sclerosis, neuromyelitis optica, diffuse cerebral sclerosis, or acute disseminated encephalomyelitis, and latest in the list, myelin oligodendrocyte glycoprotein or MAG or MOG associated disorders. The spread of disease can be bidirectional. What I mean that white matter disease starting in the brain can involve optic nerve later on, such as multiple sclerosis, or the disease can start in optic nerve and later on spread to brain, such as neuromyelitis optica. The commonest pathogenic mechanism of white matter is demyelination. Typical optic neuritis is a focal demyelinating event. It can be either an isolated demyelinating event or a part of generalized demyelinating disorder. I'll give you a classical clinical vignette of one of my patients diagnosed and treated as typical optic neuritis. She was a 27 years female, presented with the complaints of sudden onset decrease of vision in right eye for past 4 days. She reported periocular pain, which increases with eye movements. There was no systemic illness, and she was not taking any medication. On examination, her vision was 20/160 in right eye and 20/20 in left eye. She was reading 3 out of 13 color plates with the right eye, and she was reading all 13 Ishihara color plates with the left eye. Both eyes were quiet. There was a relative afferent pupillary defect in right eye. There were no cells in AC or vitreous. On fundus examination, disc was pink and well-defined, and macula was dry. Her visual field 24-2 showed generalized or diffuse field loss. This is a very classical description of typical optic neuritis. To label a patient of optic neuritis as typical optic neuritis, it should have these features. The age from late teens to early 40s, unilateral decrease of vision, periocular pain, which either related to eye movements or worsen with eye movements. This has been reported in up to 97% of the patients of typical optic neuritis. There shall be color vision desaturation, visual field defect, relative afferent pupillary defect. On fundus examination, disc is normal, or there can be mild disc edema. Spontaneous improvement of vision is a rule. Vision impairment in typical optic neuritis may range from 20/20 to no light perception. 20/20 vision does not exclude the diagnosis of optic neuritis, because Snellen visual acuity is not the only way to access optic nerve function. Color vision and contrast sensitivity speaks volume about optic nerve dysfunction. In same breath, I would like to say no light perception is not a reason to withhold treatment in the case of optic neuritis. In other specialty of ophthalmology, such as glaucoma or retina, if you have a patient of no light perception, you say there is no visual potential and you do not intervene. But this is not the scenario in neuro-ophthalmology. If you have a patient with history of recent decrease of vision, and at presentation, patient is having low light perception, and on clinical examination, you feel that this decrease of vision or loss of vision is due to optic neuritis, treat such patients. Because in my observation, and not only mine, in the observation of other neuro-ophthalmologists also, such patients gain substantial vision after treatment. So no light perception is not the reason to withhold treatment in optic neuritis, and 20/20 vision do not exclude the diagnosis of optic neuritis. In typical optic neuritis, color impairment is disproportionate to Snell's acuity, and RAPD is the most sensitive and objective test for optic nerve dysfunction, except one caveat. There is one situation in which there can be optic neuritis, but still you may not see relative afferent pupillary defects. If you have a patient of optic neuritis and he had subclinical optic neuritis in contralateral eye, and at the time of examination, both optic nerves are equally damaged, then despite of current optic neuritis, you may not see RAPD. But this scenario we encounter seldom. How to exploit the combination of vision, color vision, and RAPD to diagnose optic neuritis? I will give you 3 clinical scenarios. For the sake of ease of description, I have kept the duration of symptom to the 5 days and laterality of eye eye to the right eye. I have selected the female gender because optic neuritis and multiple sclerosis is 3 times common in females compared to male. So case number 1, these are the basically actual cases which I have seen in, in our hospital. So this female patient presented with complaint of poor vision for past 5 days. On examination, vision was 20/20 in the right eye, sorry, 20/22 in the right eye, 20/20 in the left eye. On leading questions, she accepted periocular ache. Both eyes were quiet, disc was pink and well defined. And with this information, initial impression was a normal examination. But as patient was adamant that she's having some blurred vision for past 5 days, we checked her color vision. She was reading only 6 out of 13 color plates with the right eye, and she was reading all 13 plates with the left eye. On meticulous pupil examination, we found relative afferent pupillary defect, and the diagnosis changed from normal examination to retrobulbar optic neuritis. This case tells us that a mild blurring of vision is, or rather you can say that a normal visual acuity does not rule out the possibility of optic neuritis. And there is a disproportionate color vision loss. The vision in the right eye is 20/22, but the color vision has gone by 50%. She is reading only 6 out of 13 plates. So this is a classical scenario in retrobulbar optic neuritis. Case number 2. Again, this female patient presented with the complaints of poor vision in right eye for past 5 days. On examination, she was having 20/80 vision in the right eye and 20/30 vision in the left eye. She was hypermetrope of +5 diopter, and she underwent refraction 2 years ago. She denied pain with eye movement. On examination, discs were pink and small with query blurred margin in the right eye. The initial impression was hypermetropia, and patient was advised to go for refraction. But again, the visual complaint was of only 5 days duration. We checked the color vision. She was reading only 3 out of 13 plates, and she was reading all 13 plates with the left eye. On pupil examination, there was relative afferent pupillary defect in the right eye, and the disc was small, but on top of that, there is a slight blurred margin. This was the case of papillitis. So it is very tempting to say that refractive error can be a reason for blurring of vision, especially if the refraction was done long ago. But in this scenario, there's a disproportionate loss of color vision compared to visual acuity. Case number 3, the female patient presented with complaint of poor vision in the right eye for past 5 days. Her vision was 20/160 in the right eye, 20/20 in the left eye. She denied any pain with eye movement. Her color vision was, she was reading 8 out of 13 plates with the right eye and reading all 13 plates with the left eye. On examination, there was RAPD. But this was pale. This is not optic neuritis. First thing, the color vision loss is proportionate to Sunil acuity loss. Her vision is 20/160, and she's reading 8 plates out of 13 plates. The proportionate color vision loss, RAPD is there, but this pale or pale disc is not a feature of typical optic neuritis. Because for any inflammation to cause disc pallor, it requires minimum 6 to 8 weeks. But the history is there only for past 5 days. So these are the few clinical scenarios in which you can exploit the color vision, Sunil's acuity, and RAPD to diagnose typical optic neuritis. To classify an optic neuritis as atypical optic neuritis, it should have following feature: age 50 or above, bilateral simultaneous loss of vision, severe pain or headache or no pain at all, marked disc edema, numerous hemorrhage at disc or peripapillary area, cells in AC or vitreous, macular edema or exudates, and no recovery of vision after 1 month. Why we should or subclassify an optic neuritis into two groups, typical and atypical. Because if we say the optic neuritis is typical, then the etiology of demyelination, etiology is demyelination until proven otherwise. But if you have a case of atypical optic neuritis, then etiology may or may not be demyelination, and you have to widen your area of differential diagnosis, your range of differential diagnosis. Well, let us walk down the memory lane of history and recall a movement of pride from archives of medicine. Kendall, Reistein, and Hench were awarded Nobel Prize in Physiology for isolation of cortisone. And this is a screenshot from a video clip of prize distribution ceremony, Nobel Prize distribution ceremony in 1950. And you can see Kendall, Reistein, and Hench are walking to receive Nobel Prize. Merck was first pharmaceutical company to produce and provide cortisone commercially. It used to cost $200 per gram, equivalent to $2,100 in 2020. Because it was a new drug, production was limited, and everyone wanted to use it in every thinkable disease. Initially, the supply of cortisone was allocated by a committee appointed by US National Academy of Sciences. Despite the restricted availability and the sky-high cost, cortisone was used to treat optic neuritis in 1952, that is within 2 years of its isolation. Over the next 3.5 decades, many clinical researchers used steroid to treat optic neuritis and suggested a possible benefit. In 1988, Spoor and Rockwell from Detroit treated optic neuritis with intravenous methylprednisolone first time. They treated 12 patients with IV methylprednisolone and reported 100% visual recovery. Publication of results of trial conducted by Spoor and Rockwell paved the way for the optic neuritis treatment trial. On 1st July 1988, ONTT was started by National Institute, US. ONTT is one of the landmark studies in ophthalmology, and results of this study provided universal guidelines to treat and prognosticate optic neuritis. I will narrate this study in next few slides and present results in bit details. ONTT was a multi-center, prospective, randomized, placebo-controlled, single-blind, interventional clinical trial. 15 renowned universities participated in this landmark trial, and the observations of 15 centers were collated at a data coordinating center and visual field reading center. Patients recruited in ONTT were between 18 to 46 years of age, suffering with acute optic neuritis with visual symptoms for 8 days or less. There was relative afferent pupillary defect and visual field defect in the affected eye. There was no previous episodes of optic neuritis in affected eye. There was no previous corticosteroid treatment for optic neuritis or MS, and there was no systemic disease that may cause optic neuritis. ONTT was designed to determine the natural history of vision impairment due to optic neuritis, to assess the beneficial and adverse effects of corticosteroid treatment for optic neuritis, and to identify risk factors for the development of multiple sclerosis in patients with optic neuritis. Total 448 patients were randomized to one of the three groups. Group 1 was treated with oral prednisolone 1 milligram per kg per day for 14 days. Group 2 was treated with IV methylprednisolone 250 milligram, every 6 hours for 3 days, followed by oral prednisolone 1 milligram per kg per day for 11 days. And group 3 was treated with oral placebo for 14 days. The results of ONTT were published in 1991 in Archives of Ophthalmology under title The Clinical Profile of Optic Neuritis, Experience of Optic Neuritis Treatment Trial. I will narrate the results of optic neuritis treatment trial. Optic neuritis treatment group found that optic neuritis resolved and improvement of vision occur in most of the patients. Group 1, which was treated with oral prednisolone, and group 3, who were treated by oral placebo, recovered vision in 6 to 8 weeks. But the group 2, who were treated with IV methylprednisolone, the recovery of vision was faster by 2 weeks. Interestingly, ONTT did not find any effect of treatment on final visual acuity at 6 months. The quantum of optic nerve function recovery was same at cutoff point of 6 months, irrespective of treatment modality, that is IVMP, oral prednisolone, or placebo. From the point of view of speed of recovery of vision, IVMP may accelerate the vision recovery by 2 weeks. Another interesting finding of ONTT was that most patients with poor vision recovery have poor vision at onset, but many patients with poor vision at presentation improve dramatically after treatment. Well, no light perception, this is not the result of ONTT, but I feel it is appropriate to club this information in this slide, that no LP shall not be a reason to withhold treatment in optic neuritis. Secocentral scotoma was considered commonest field defect of optic neuritis. ONTT found that central or secocentral scotoma is most typical, but diffuse field loss is the commonest visual field defect. Recurrence of optic neuritis in same or contralateral eye occurred in all 3 groups, but recurrence rate was double in oral prednisone group compared to IVMP or placebo groups. No clinical MS at enrollment was inclusion criteria of ONTT. ONTT observed some very interesting findings about MS. Asymptomatic white matter lesion on MRI are the strongest predictor of MS. This slide shows asymptomatic white matter lesion, and these lesions are the strongest predictor of MS later on. I just want to add one more thing here, that you must remember that at the time ONTT was started in 1989 to 1991, neither there was a gadolinium contrast nor there was a flare sequence of MRI. So the interpretation of white matter lesion at that point and interpretation of white matter lesion today is entirely different. Today we use GAD enhancement and flare sequence extensively to correlate white matter lesion with MS. Another interesting result of ONTT was incidence of MS at 2 years if somebody have optic neuritis and abnormal MRI. What I wish by word abnormal MRI, that they have 2 or more hyper intense lesion which are 3 millimeter or more in size. I've already shown you what I mean by white matter lesion. And if somebody have optic neuritis with abnormal MRI and treated with IV methylprednisolone, the incidence of MS at 2 years was 7.5%. If treated with oral prednisolone, incidence of MS is 14.7%, and if treated with oral placebo, the incidence is 16.7%. So IVMP reduce the chance of developing MS by more than half. This is a very important observation of ONTT. This graph shows the incidence of MS, or this graph shows relationship of number of hyperintense lesion in MRI and percentage of clinically definite MS at the interval of 5 years after ONTT. So if somebody have optic neuritis and on baseline MRI there is no hyperintense lesion, then chance of developing MS is only 16%. But if somebody have 1 to 2 lesion at baseline MRI, then chance of developing MS at 5 years is 37%. But if lesion are 3 or more, then chance of developing MS are 51%. So more the lesion on MRI, more the chance of developing MS. Okay. At present, neither we are using any of the 25 home remedies mentioned in this book, nor oral corticosteroid to treat optic neuritis. After ONTT, we have universal protocol to treat optic neuritis, that is IV methylprednisolone, 1 gram per day for 3 days, followed by oral prednisolone, 60 milligram per day for 11 days. After publication of result of ONTT, there were 3 follow-up studies at 5 years interval, which were called longitudinal optic neuritis study, or LONS. Cumulatively, these LONS prognosticate vision and incidence of MS over the period of 15 years following a bout of optic neuritis. This is a LON, or longitudinal optic neuritis study, published in American Journal of Ophthalmology in 2004, entitled Visual Function More Than 10 Years After Optic Neuritis. According to this longitudinal optic neuritis study, most patients retain good to excellent vision 10 years after attack of optic neuritis. They found recurrence of optic neuritis is the most common in patients with MS. This is another study published in Archives of Ophthalmology regarding high and low risk factor for developing multiple sclerosis 10 years after optic neuritis. According to this study, they found that despite brain lesions seen on MRI, more than 40% of the patients of optic neuritis will not develop clinical multiple sclerosis after 10 years. So half of the patient with white matter lesion following optic neuritis will develop MS, half will not develop MS. According to LONS, that male gender, no light perception at presentation of optic neuritis, no pain at presentation, marked disc edema, peripapillary hemorrhage, and normal MRI scan are associated with low chance of developing MS after a bout of optic neuritis. An extensive clinical profile of optic neuritis and its association with multiple sclerosis is provided by this landmark study. During past 3 decades, based on ONTT observations, approximately 50 articles are published. While basking in the glory of ONTT, we simply ignore the fact that albeit ONTT answered many questions, it raised some questions also. After ONTT, most of us stopped treating optic neuritis with oral prednisolone, but no other study has confirmed the increased recurrence of optic neuritis in patients treated with oral prednisolone. ONTT was unable to explain why recurrence of optic neuritis was higher among patients treated with oral prednisolone. Is higher incidence related to route of administration, that is oral versus intravenous, or molecule of steroid, that is prednisolone versus methylprednisolone, or dose of steroid, that is 60 milligram versus 1000 milligram? And if ONTT claim that it is the cumulative effect of route, molecule, and doses, then why should we supplement IVMP with oral prednisolone for 11 days? To answer this question, Morrow and group published an article in JAMA Neurology 2018, effect of treating acute optic neuritis with the bioequivalent oral versus intravenous corticosteroid. This study was designed to assess the recovery of demyelinating optic neuritis after treatment with equivalent high dose of oral versus intravenous corticosteroid. Bioequivalent dose of 1000 milligram intravenous methylprednisolone is 1250 milligram oral prednisolone. So patient was randomized to one of the two groups. Group 1 received oral prednisolone 1250 milligram daily for 3 days, and group 2 received IV methylprednisolone 1 gram daily for 3 days. Interestingly, they found at 1 month and 6 months, vision and p100 latency recovery was identical in both groups. So if you believe this study, prednisolone was not a bad boy, rather its potential were not exploited fully. We half treated the patient. Second question from ONTT, does time of intervention affect outcome? ONTT enrolled patients within 8 days of onset of symptoms. But the question comes, if patient come 2 to 3 weeks after the onset of symptoms, or if symptoms start resolving spontaneously, irrespective of duration of symptoms, shall we treat or not? To find appropriate time window for intervention in optic neuritis, Gordon Plant and group conducted this interesting study at Moorfield, King's College, and National Hospital for Neurology and Neurosurgery, UK. This is a very interesting study because they recruited the patient with a past history of optic neuritis who suffered pain at the time of optic neuritis. And these patients were advised to come back immediately if they ever suffer from similar pain but without change in vision. The patient who reported back underwent urgent MRI orbit to document recurrence of optic neuritis, prior visual impairment. Patients with MRI confirming optic neuritis were treated with IV methylprednisolone. And they reported that none of the 5 patients who suffered with the optic neuritis in past and came back at the stage of periocular pain without any decrease of vision, the methylprednisolone did not allow vision to decrease. So treatment at the stage of ocular pain preceding visual loss may abort the disease process and patient will not suffer vision loss. This is called hyperacute treatment. So hyperacute corticosteroid treatment of optic neuritis at the onset of pain may prevent vision loss. So we can see that early we act in optic neuritis, better it is. Though this depends upon a subjective finding, and patient should be very astute observer that he realize that it is the same pain which he suffered with 4 years ago when he suffered with optic neuritis. So chance of getting the patient in the hospital at the right time is a bit unlikely. But still, they have proven that early intervention is crucial or important in treatment of optic neuritis. Third question, oral versus IV methylprednisolone. ONTT did not elaborate, is IV route is a must or methylprednisolone can be given orally. Ramotello conducted this study entitled A Randomized Clinical Trial of Oral versus Intravenous Methylprednisolone for Relapse of MS, published in 2014. The bioequivalent dose of 1000 milligram intravenous methylprednisolone is 1250 milligram oral methylprednisolone. And the outcome of oral methylprednisolone was not inferior to intravenous methylprednisolone in treatment of relapse of MS. So this study suggests that we can give oral methylprednisolone compared to intravenous methylprednisolone. Okay, we have discussed a lot. Now time to take home message. Now after ONTT, we have a universal guideline to treat optic neuritis. We should not treat optic neuritis with oral prednisolone alone. Long-term visual prognosis is very good in most of the patients of optic neuritis. Diffuse field loss is the commonest visual field defect in optic neuritis. White matter lesions are strongest predictor of MS, so baseline MRI is mandatory in all patients of optic neuritis. Despite white matter lesion, half of the patients of optic neuritis will not develop MS. If a patient of optic neuritis have white matter lesion, IVMP decrease the chance of developing MS by half. This is a take-home message from optic neuritis treatment trial. Now, from the new studies, we can construe that high dose of oral prednisolone is as good as IV methylprednisolone. Early initiation of treatment in optic neuritis can abort visual deterioration in incipient optic neuritis. And oral methylprednisolone is as good as IVMP in the treatment of optic neuritis. One of the most debated observation of ONTT was that IVMP for optic neuritis partially protect a patient from developing MS for 2 years. As you remember that I told in ONTT results that incidence of optic neuritis was less in patients who were treated with IV methylprednisolone. So this is the most debated observation of ONTT. I often contemplate that if IVMP provide protection from MS for 2 years, why shall we not give IVMP every 2 years to all patients suffering from a bout of optic neuritis? Even if it gives a partial protection, there is some protection. So that increase the chance of developing MS, which is a very incapacitating disease. So I would like to conclude my session that we have exploited the ONTT to the maximum, and time has come to think about ONTT part 2. Thank you.
Thank you, Dr. Sunil, for the interesting lecture. Now we'll open the discussion. If you have any question, you can raise a hand or you can tap the question and we'll read it for Dr. Sunil. Dr. Ahmed Khalaf is raising his hand, so you can.
Yes, thanks a lot for your presentation. I was asking about the slide where you showed 3 different cases with optic neuritis and retropalpar neuritis and papillitis. You were mentioning a numerical grading from 15. Sometimes it was 8, sometimes it was 3. So I was wondering what was the ranking actually? What is the 13 category? And if you can show the slide again so you can explain it more. Thanks.
Doctor, in that slide, I don't know whether I can. I don't know I can share that slide or not, but what I wish to convey is that in disproportionate color vision loss. So the Snell acuity can be slightly impaired, but color vision is dramatically less. So I just give you some idea. For example, in the first slide, I say that vision is 20/22, and the patient is not reading Let me see. Patient is not seeing seven color plates. So the color vision is much more loss. You can say color vision loss is much more pronounced compared to Snell acuities. This is one of the typical feature of optic neuritis. Similar in second slide, I just want to emphasize that loss of color vision is much more compared to the Snell's acuity. That was my intention.
So the 13 was grading of the color vision of the patient.
Yeah. That is just how many plates he or she is reading from Ishihara color plates. So we check color vision in our hospital by using Ishihara color plates. We let the patient read first 13 plates, and then I have mentioned here that he or she is reading 6 out of 13 plates or 13 out of 13 plates.
Okay. So my second question was for the third case, which was having RAP, that wasn't diagnosed as optic neuritis.
Yeah.
So what was diagnosed actually in that case?
No. Now it is a case of just optic atrophy, and we have to just find out why there is optic atrophy. It is not an optic neuritis, so it does not need any treatment right now. It needs further workup. Because if we say it is optic neuritis, whether it is papillitis or retrobulbar optic neuritis, we want to treat the patient. But here in this scenario, I just wish to convey that it is not optic neuritis. It does not need any treatment. It needs workup to find out why disc is pale.
That was also a differential diagnosis for RAB, that not each RAB meaning neuritis, optic neuritis.
Yeah, of course.
Okay, thanks a lot.
So,
Dr. Sunil, I see one question from Ahmed Ali. He's asking, is there any role of interferon in the treatment of optic neuritis and MRI brain lesion?
okay, interferon is a treatment of multiple sclerosis, not of optic neuritis.
If you may, Doctor, you can see the chat. There are lots of comments and questions.
No, yeah, and sure. Okay. Yeah, I can see it. So let us start from question. What is your protocol for treating patients with and without white matter? Okay, Dr. Abdul Rahman, we'll start from Dr. Abdul Rahman. So in summary, what is your protocol for treating patient with and without white matter lesion? Okay, so basically the purpose of treating optic neuritis is twofold. First thing is the early recovery of visual acuity. Second thing, protection from development of MS. Okay. If somebody have, you can say that mild decrease of vision and there is no MRI lesion, we can withhold the treatment. Of course, after discussing with the patient. But if somebody have no white matter lesion, but severe loss of vision, we should treat the patient from the point of view of vision. But if somebody have loss of vision along with white matter lesion, definitely treat such patients. Dr. Rikha Elena, when do we start to give IENP? Sometimes we need time to do some examination to make diagnosis. Okay, what we do, I do not know what examination you order in case of optic neuritis. Basically, what I do in my hospital, I just, if I made the clinical diagnosis of optic neuritis, I would like to go for MRI. Okay. And then meanwhile, I will just do the blood workup, rule out any contraindication for steroid treatment. For example, biochemistry or any general workup and I send the patient to medicine department. If they say clear, go for steroid, I will start. If you want to write something specific so I can answer it better. Hyperacute corticosteroid means IVMP followed by oral or IV alone. No, 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 no. There's hyperacute means that you are giving steroid before the patient develop vision loss. Okay. Natural event in typical optic neuritis is a 2 or 3 days of periocular pain. Then there is a visual impairment, and then within next 1 to 2 or 3 days, that periocular pain disappear. This is a natural sequence of event. But in hyperacute corticosteroid means this study was done by Gordon Plant in Moorfield, and they recruited the patient who suffered with optic neuritis in past, and they told these patients that if you ever develop the pain, similar pain like optic neuritis pain, come back to us. And the patient came to them prior to onset of vision loss. So there was pain only, but there's no vision impairment. And they start treating the patient at that point only. But the one basic, you can say that apprehension in this study is that patient should be very astute observer. He should recall the pain and then compare to the current pain, and then they should have the urgent MRI facility. Because if they wait for MRI like we wait in our hospital or anywhere also, then by that time the vision loss already occurred, and this whole purpose is being defeated. They want to treat the patient in the small window when the pain is there, but vision loss is not there. Dr. Dulwa, why don't you treat with oral prednisolone, optic or it was 60 minutes? Yeah. That's what I said, that maybe the reason that we have high recurrence rate in ONTT in prednisolone group is because we did not give the full dose. This is not the right simile, but what I feel that like we give a half-hearted antibiotic course, and with ONTT, they treated with prednisolone half-heartedly. They give 60 milligram only. While in comparison to that, they give 1 gram methylprednisolone. And now we know the bioequivalent dose of 1 gram methylprednisolone is 1250 milligram. That's what Morrow and group has shown in their publication. Difference between optic neuritis and papillitis. Optic neuritis have two types, or rather two parts. If there is a disc edema, it is papillitis. If you don't see anything, it is retrobulbar optic neuritis. So retrobulbar optic neuritis plus papillitis equal to optic neuritis. Or in other words, if you see the intraocular part of optic nerve, that is disc inflamed, that is papillitis. If you see retroocular part of optic nerve inflamed, that is retrobulbar optic neuritis, and both combined call optic nerve. Is there any difference in treating optic neuritis due to MS or NMO? NMO is an entirely different thing. Okay. Treatment wise, you can say that we have fixed protocol for treating optic neuritis due to MS, but this protocol may or may not work in neuromyelitis optica. Sometime or rather to begin with, we try IV methylprednisolone, and what I do that if I'm suspecting NMO, I give the steroid IV methylprednisolone for 5 days, and then try oral prednisolone. And if it doesn't work, we can go for plasmapheresis, immunosuppression, etc. That is an entirely different group of disorders. Is there any role of retrobulbar triamcinolone injection? No, I do not know. I do not know. I have not seen anybody giving it, nor I have read. IMP need hospital admission. Is there a justification to initiate with high dose oral prednisolone with the previous case report? Okay, what I will say that in our hospital, we are giving IV methylprednisolone on you can say that outdoor basis. Patient come to us, we have a room, we have facility, we give steroid, IV methylprednisolone. It takes 2.5 hour time, and then patient will go home. So it does not require admission in our hospitals. And regarding, is there any justification? Right now, we do not have the sufficient data. This is one study, but we do not have sufficient data to challenge ONTT result. So right now, I will say that keep on following the ONTT justification or guidelines till you have ONTT part 2. Will oral high dose steroid not lead to severe gastritis, which may lead to GI bleeding? And okay, I will, when we write treatment for optic neuritis, I give IV methylprednisolone 1 gram in 200 ml saline, slow for 2 hours for 3 days, once per day. And then tablet prednisolone 60 milligram per day, once a day for next 11 days. From the day one, when I'm starting IV methylprednisolone, I write antacids, or in the sense you can say that ranitidine or omeprazole, etc. At the same time, I would like to just share with you what is my style of giving oral prednisolone. I say take the prednisolone oral in bolus dose in the morning. Okay, take good amount of breakfast, eat half of the breakfast, take tablet prednisolone, finish half of the breakfast, and after finishing the breakfast, take 1 glass of milk. While you're taking prednisolone or imethylprednisolone, take 1 banana or 1 orange every day as a potassium supplementation. And I have treated dozens of cases of optic neuritis. I have not come across a single patient who came to me with GI bleeding. Well, maybe I'm lucky, or maybe this style works. Respected sir, kindly explain you scenario in which the patient has PLPR, or mention the patient will have RAPD, but how will go about the case? Respect, kindly can you explain the scenario in which the patient has PLPR? That patient. No, sir, this is not very clear what you want to ask. If somebody have PLPR or hand movement, if it is unilateral, that patient will have RAPD. Okay, that depends upon, sir. I mean, that what is the age, what is the presentation. PLPR is a vision right now. How the thing started? Suppose somebody have PLPR or some problem for last 10 years, or somebody have for last 3 days. That make a lot of change in differential diagnosis. So if you can write your question again, I can answer it. Okay, MRI report, brain with optic section, enough to confirm we shall do MRI, spine, cord, blood, and more. Okay, MRI report, brain with optic nerves. Okay.
Dr. Sunil,
Okay.
thank you so
Yes.
much. We can conclude with this question. It was very informative, and thank you, Dr. Sunil.
Okay. Okay. Bye bye.